Hello, and thank you for listening to the AT Tapes, a podcast from the Journal of Athletic Training. The goal of this podcast is to interview researchers and clinicians on current topics facing athletic trainers and discuss how we can utilize best practices to improve patient outcomes. My name is Lizzie Hibbard, and I will be your host for this podcast. Currently, I'm a faculty member in the athletic training program at the University of Alabama, and I have a research interest in shoulder and elbow injury prevention in youth overhead athletes. You can follow me on Twitter at EEHibbard. Before getting started on today's episode, I wanted to remind everyone that all content from JAT is open access, meaning it is free of charge to all readers thanks to funding from the National Athletic Trainers Association. This month, the JAT is releasing a special issue on public health and athletic training. Today's guest is Dr. Tamara Valovich McLeod. You can follow her on Twitter at Tamara CV McLeod. She is an NATA fellow and currently serves as the chair for sports medicine and is a professor and director of the athletic training program at AT Still University in Mesa, Arizona. She is the director of the Athletic Training Practice-Based Research Network, and her research has focused on the pediatric athlete with respect to sport-related concussion and overuse injuries. She was the lead author on the NATA position statement on the prevention of pediatric overuse injuries and a contributing author on the NATA position statement on the management of sport-related concussion. She was a consultant and contributing author on the appropriate medical coverage for secondary school-aged athletes. Dr. McLeod serves on numerous editorial boards and publishes frequently in athletic training and sports medicine journals. Dr. McLeod, welcome to the podcast.
Thank you for having me.
So let's get started with learning a little bit about you. Can you tell us why you decided to become an athletic trainer?
That's a great question. My mother was a nurse, and so I always had interest in healthcare, but I was very active and participated in a lot of sports as a youth. And I think just the mix of being able to combine sports and medicine together is really what set me down the path into athletic training.
So once you decided to become an athletic trainer, can you tell us a little bit about your educational background?
Sure. I did my bachelor's degree at Mercyhurst College, which is now Mercyhurst University in Erie, Pennsylvania. From there, I did my master's in kinesiology and applied physiology at the University of Colorado, but felt that took me a little bit away from athletic training. So I spent a year with the New Hampshire Musculoskeletal Institute it was a fellowship at that time. It's one of the residency programs now in athletic training. And as part of that fellowship was required to do a research project. And that really kind of got me introduced to research, and it was Julie Bernier from Plymouth State who said, you need to go to Virginia and work with Dave Perrin, and that led me to UVA, where I finished my doctoral degree.
So how has your research line evolved over your career to what it is now?
It's really kind of stayed true to the focus of the pediatric athlete. I was fortunate enough to work with Dr. Guskowitz on one of his initial projects looking at concussion in high school athletes. And as part of that, really discovered that the assessment tools that we were using did not work well in the younger individuals. And so my dissertation was really focusing on validating assessment tools for athletes under high school age. And since that time, I've really started to focus on outreach, investigating both educational issues related to concussion in stakeholders for youth sports, looking at assessment tool validation, and more recently, a lot with patient-rated outcome measures for concussion. And we're currently in the middle of a project to develop a concussion-specific youth patient report measure that should hopefully guide clinical practice and assessing and managing the patient as a whole person.
So a lot of your research really falls into this category of public health or public health aspects of it. And so this month, the Journal of Athletic Training released a special issue on athletic training and public health. And it seems over the past 5 to 10 years, there's been more and more of a discussion about the intersection of athletic training and public health. Could you start out by discussing a little bit about the discipline of public health and what are ways that athletic trainers are participating or already participating in public health education and practice?
Yeah, I think athletic trainers are public healthcare providers to some degree already. We just might not think of ourselves in that particular manner. But with public health, it's really having an eye on prevention. It's looking at population issues related to health and health status and healthcare, not necessarily just at an individual person level. It's being an advocate, working on things like policy and legislation, and really trying to look through the lens of how disease and injury affects not just the whole person, but the entire population. And I think athletic trainers are very well positioned and in a unique role to contribute to society as public health care providers.
So there are 10 essential services of public health that have been identified and are out there to look at. So could you highlight maybe a few of these and how some of these align with the athletic training domains or clinical competencies?
Yeah, I think the biggest thing that comes forward is one of our domains is prevention. And I think sometimes athletic trainers don't necessarily do the best job with prevention, but it's certainly an area that sets us apart. So I think that being an athletic training domain, as well as the new KD standards requiring professional programs to instill in students foundational knowledge in both public health and epidemiology, kind of leads to some of that framework. And when we look at those essential services, diagnosing and investigating health hazards and problems in the community. Athletic trainers do that all the time. It can be anything from as simple as evaluating injury trends at your own clinical site to looking at injury trends across a larger population. The essential element of informing and educating stakeholders. Athletic trainers do that all the time with athletes, with parents, with coaches. Development of policy and plans that support both individual and community health efforts. Athletic trainers are on the forefront of research in a number of different areas that lead to policy. Heat illness, concussion, they're involved in a lot of that, enforcing laws and regulations, and then linking people to needed health services. I think another role that an athletic trainer often plays that may get overlooked is one of the case manager. In that they're seeing the patients, but then they're deciding to whom they're going to refer, who becomes part of that patient's care team, and they serve as that point person throughout that injury process, and that's another essential element of public health.
So as you look at these essential services of public health, what are areas that you see that athletic trainers could improve upon or sort of learn from this model to better the outcomes for our patients?
So I think there's two key areas, and I think they both actually relate to documentation. In some instances at the local site, when we start to look at injury trends and the epidemiologic aspects of illness and injury, a lot of that really comes down to adequate documentation that athletic trainers need to be doing and contributing to some of the larger efforts, such as the NCAA injury surveillance system, the high school Rio, or the NATA Nation. And instilling kind of that mentality that it's important to be doing that kind of work. It's not something extra we're just trying to add on. And I think also collecting patient outcomes is extremely important. If we want to evaluate the effectiveness of care and be able to make some broad statements about athletic training services at a greater level, we need to do a much better job at collecting a number of different outcomes from both the clinician and the patient perspective.
So in your own research and other parts of your day, you're the director of the Athletic Training Practice-Based Research Network. And the ATPBRN is an affiliate network of the Agency for Healthcare Research and Quality and is the first and only practice-based research network in athletic training. So can you tell us a little bit more about the ATPBRN and the work that's conducted through this network?
Sure. The ATPBRN was initially developed back in 2009 as a result of a lot of study that we had been doing as a group within our athletic training program here at AT Still University. And part of what we recognized was if we needed to teach our students things like evidence-based practice, clinical outcomes assessment, health information technology. There had to be a better way to do it and to try to get them to integrate it into their practice. And kind of serendipitously, through a lot of our research as we were actually doing our program self-study, we came across the whole concept of practice-based research. And we kind of sat there and said, well, this is exactly what we're talking about. We didn't know that had a name. And more work that we had done had really started to identify what practice-based research networks were, which is really groups of clinical practice sites that use some type of common documentation system that allow the collection of a lot of healthcare data. It's not specific to one particular study, but it just becomes a mechanism to allow a lot of other studies. So it differs from what we might think of a multi-site study that's kind of a one and done, something gets sets up for a specific research question, whereas a practice-based research network infrastructure is really more than that. It's setting something up for multiple types of studies that can occur with various clinical practice sites, depending on the research question being asked.
So how do you select the schools that are included as these clinical practice sites?
Yeah, it's really them coming to us. A lot of the sites where our students have graduate assistant positions, we highly recommend that they're using the Core AT EMR, which is our documentation system. But otherwise, it's schools that want to use an electronic medical record that might have limited resources. We do not charge for ours. And so it allows them a free documentation record. And from the clinician standpoint, you know, I'm not quite sure how many of them actually see themselves as members of the PBRN. They're using a system to document, but collectively, we can start to look at de-identified data on the back end and start to answer some important research questions about characteristics of athletic training practice, costs of services provided by athletic trainers, patient outcomes, and a number of different types of research questions.
So how does a school or an individual become involved? What's the best way to contact you all?
Yeah, the best way is to contact on the PBRN website. There is a link for a free demo login. And then if someone is kind of ready to jump in, start to use the EMR, join the PBRN, we do have a series of training and onboarding videos to ensure quality documentation, ensure that they understand the system and how it works. And then we just work to get them set up and they start to use it.
Great. So one of the things that I've always really respected about the AT-PBRN is that in addition to creating research, you all are invested in the dissemination of your findings. And I recently saw a post that through the AT-PBRN, you all have delivered over 55,000 EBPCU hours. So, which I'm sure is even higher now than when I originally saw that. So can you tell us a little bit more about these EBP course offerings?
Sure. Yeah, another facet, obviously, of practice-based research networks is kind of disseminating information back to participating clinicians in addition to publishing, and serving as a mechanism for research and education for those clinicians. So we initially started developing continuing education courses related to some key areas where we were teaching courses within our curriculum. We've taught an evidence-based practice course since 2008, same thing with a patient-oriented outcomes course. We offer courses in quality improvement, health information technology, which now when you look at the KD 2020 standards, these are all core competencies that the National Academy of Medicine requires for all healthcare providers that are going to have to be taught in all levels of athletic training education. And so, you know, we figured to give back to the AT profession, we would start to take some of the content, break it down into some smaller pieces, and we currently offer 9 EBP CEUs in areas of evidence-based practice, clinical outcomes, health information technology, and even more clinical courses like best practice for concussion management. And Sue Falsoni has developed one on pain and pain management. We also have a Category A course on medical legal aspects of concussion to really kind of hone in on the importance of documentation. And then later this year, we'll be releasing 3 more EBP courses, one on ankle rehabilitation, one on diagnostic accuracy, and the last on lower limb injury prevention programs. And so knowing that the reporting cycle is going to be coming to an end at the end of this December, I can certainly see those numbers going up. But we just feel it's a way to give back to the athletic training profession and provide some additional education in the form of CEUs.
And these EVP and category CEUs are free, correct?
They are all free.
So an important question that people frequently have. But the ATPBRN has a great website with information about becoming a clinical practice site, some of their research findings, and these EVP course offerings. And the web address is www.coreat.org. And you can also follow the ATPBRN on Twitter at ATPBRN. So shifting gears a little bit, I want to talk a little bit about one of your recent publications. So you and your colleagues have an article published in the JAT special issue that's titled Emergency Preparedness of Secondary School Athletic Programs in Arizona. You all surveyed high schools in Arizona to describe the emergency preparedness of these schools, specifically on emergency action plans, cardiac arrest, concussion, and heat illness, and a few other policy questions. It was encouraging to read that 81% of the responding schools had access to a licensed athletic trainer. While this was positive, there were also a lot of opportunities for improvement that were presented. So can you talk a little bit about some of the findings in regards to the emergency action plans at the high schools and how other clinicians can use this information to ensure that they're using best practices?
Sure. This particular study was an effort that stemmed out of work that the Arizona Interscholastic Association Sports Medicine Advisory Committee had been wanting to do, looking at some of the collaborative solutions meetings that the National Federation and the NAT had done together to try and identify best practices that really focused on head, heat, heart, and emergency action plans. And so we felt it was important, if we're going to be making statewide policy decisions, to really get a lay of the land as to what's going on. And so we surveyed athletic directors of Arizona high schools, and with respect to the EAP, we found mid 90% had an emergency action plan. And so when, that was promising, but when we started to dig down deeper into what would really be a good emergency action plan, having venue-specific emergency action plans, rehearsing emergency action plans, our percentages that were in compliance with some of those best practice recommendations started to drop off. And so while we see a lot with an EAP, there are a lot of schools that don't practice their EAPs regularly, and that is certainly an area for improvement. What was encouraging, though, was with respect to a lot of those subcomponents related to the EAP, was schools that had access to an athletic trainer had significantly higher compliance with a number of those recommendations. And so it helps us from a committee standpoint in developing policy is to try and figure out where do we need to educate schools and athletic directors further, and to, again, continuously advocate for the need for athletic trainers and how they can be beneficial to schools in establishing good policies related to EAPs and other areas, as well as hopefully decreasing liability to some of those schools by having adequate policies in place.
So there was a lot of results in there, and obviously we're not going to have time to talk about all of them, but what are some of the other key findings from the research study that you really think should be highlighted so that other clinicians can sort of evaluate their own practice behaviors and be thinking about what if they're on the right track in their settings?
Sure. I think from a 10,000 foot level, when we ask the initial questions of, do you have a concussion policy, a heat illness policy, or are you aware of the state policy for those particular areas? The number of schools who responded positively were in the 90%. It was when you started drilling down to more specifics about policies that we identified areas that could be improved across all of the conditions that we surveyed. And the other, I think the second piece that was interesting is when we looked at the role of the athletic trainer, or AT access, on a number of the policies, they were significantly in favor of having the AT having a higher compliance, except for concussion. There were no differences on any of the concussion elements between those that did and did not have access to an AT, which leads us to wonder whether or not, because of state law, schools are more apt to follow that. There's been a lot more emphasis on concussion, perhaps, as opposed to heat illness or some of these other areas. And it really gets into, having a law the stick that really gets people into compliance, or are there other ways that we can try to educate our high school stakeholders to ensure that just because there's not a state law for a condition doesn't necessarily mean it's not important to have a good, sound policy in place.
So we have linked to the article in the Journal of Athletic Training in the notes section of this podcast. And so hopefully everybody will go there and read the full results and discussion. But what are some of your overall conclusions following this research study, and how you plan to use this information as you move forward?
Yeah, as we move forward, I think some of the big take-home points are that we're not necessarily doing as bad as some might indicate. I think there was a lot of concern when the ranking of high schools had come out of the states and their compliance. A lot of our results were encouraging, but from a committee standpoint, what we're focusing on now is those smaller details to make the policies better. We think that most of the high schools understand the big picture to have a policy, but really need help with understanding the nuances of the policy. So for example, while close to 98% had a heat illness policy, only 71% had access to a cold water immersion tub. And we know that is key in having an adequate heat illness plan. So how do we go about sharing that information, educating athletic directors in schools, and then perhaps supporting them if finances or other barriers are currently in place that don't allow them to have some of the equipment that we think is important.
Well, I'm very appreciative of your time and expertise today that you shared with us. So as we finish up this episode, can you provide your take-home message on the intersection of athletic training and public health, and how the information discussed today could be used to impact clinical practice?
Sure. I think athletic trainers are primed to be advocates for public health and play perhaps a larger role than they currently do. And that can start, at the local level where they're evaluating their own policies. They are advocating for improved policies that will ultimately help with the health of their patient population. But then I think collectively as a profession, we can really start to look at some of these key areas where athletic trainers have expertise: injury prevention, concussion, heat illness, and really use our knowledge and skills to advocate across the board for improved policies, improved education among other healthcare providers and other stakeholders that will, in some light, advocate for the profession as well as to the importance and demonstrate the understanding and knowledge of athletic trainers.
Dr. McLeod, thank you so much for joining us today and sharing your knowledge.
You're very welcome. Glad to do it.
I hope you all found this podcast informative and that you can utilize the clinical recommendations to improve patient care. Please remember to rate and subscribe to the podcast wherever you get your podcasts. Also, please follow the Journal of Athletic Training on Twitter, Facebook, and Instagram at JAT_NATA on all 3 platforms. Thank you for listening, and I hope you will join us for next month's episode of the AT Tapes.